Hi, so we can get started, and I'm sure we'll be joined by many more. Um, my name is State Senator Phil Boyle. I represent the 4th State Senate District. I want to thank everyone for joining us today. This is the first of a new event we've done. As in my office, we do many events every single week, but this is a new one, and it should be very fascinating. It's our first virtual debate series. And we're going to do this monthly on controversial topics and with different experts to get their analysis and to have constituents and others ask questions. I'd like to give a shout out to our intern, Eddie Salkowski, for helping us do this today. And it's important, I believe, after many years in public service, you do have certain positions on issues, but it's always important to hear both sides in a respectful debate. And I think we need a little more of that in our society. I think we'd all agree. And I know that's going to happen here today. Today is a debate on medical aid in dying. It was started by a piece of legislation that a colleague of mine, Senator Diane Savino, has sponsored for a number of years. It's S6471, for those of you who want to look it up. It currently has 13 co-sponsors. It was first introduced in 2016, and it's currently in the Senate Health Committee. In essence, it's to provide mentally competent, terminally ill patients the ability to request medication to be self-administered for the purpose of hastening the patient's death. Now, in today's debate, the format will be this: we have two speakers. We're going to have each speaker give them 10 minutes to introduce their position on the topic of assisted suicide, both pro and con. And we are very fortunate to have the speakers here today. After that, we're going to open it up for questions. I think it's a good idea. Probably since we have so many people going to be joining us today, if you can raise your hand, and I have staff people that can recognize you, or better yet, you can put your question to either side in the chat, and we can read it that way. Of course, with 170 people, we're not going to get to everyone. I'd like afterwards, if you put your question in the chat, we can get an answer after the fact about the legislation or the issue, and then we'll give each side 3 minutes for closing arguments. As for the speakers, we're extremely lucky to have two individuals of this caliber today. Our first on the side in favor of the legislation assisted suicide is Corinne Carey. She's the senior campaign director from Compassion and Choices. Compassion and Choices is the nation's oldest and largest national nonprofit organization working to improve care, expand options, and empower everyone to chart their own end-of-life journey. Corinne Carey joined Compassion and Choices as a campaign director in August of 2015. She led the successful campaign for the New Jersey's Medical Aid in Dying for the Terminally Ill Act, which took effect on August 1st in 2019. Corinne joined Compassion and Choices after nearly a decade with the New York Civil Liberties Union, where she served as Deputy Legislative Director. At NYCLU, she engaged in advocacy around a wide range of civil liberty issues, concentrating on public health. Prior to that, she was a researcher in the U.S. program at Human Rights Watch. Corinne holds a master's degree in American Studies from the University of Buffalo, and she graduated summa cum laude and first in her class from SUNY Buffalo School of Law in 1998. On the con side, we have Jason Mcguire, spokesperson for the New York Alliance Against Assisted Suicide. Jason Mcguire serves as executive director of the New Yorkers for Constitutional Freedom and as the president of its affiliated educational arm, New Yorkers Family Research Foundation. Mr. Mcguire has been on staff with the organization since 2007 and has been an integral part of the continued growth and impact of the organization since that time. Additionally, and most pertinent to the issue at hand, he serves as a spokesperson for the New York Alliance Against Assisted Suicide. The website is nosuicideny.org. The New York Alliance Against Assisted Suicide is an informal association of many diverse organizations, institutions, agencies, and individuals in the Empire State committed to preventing the legalization of assisted suicide. They include representatives of the following communities: disability rights, patient rights, healthcare, civil rights, senior rights, and various faith-based advocacy organizations. Mr. Mcguire and his family reside in the Rochester, New York region. I will now give each side 10 minutes, and Miss Corinne, I believe, are you going first?
I am.
Okay, great. Well, thank you very much, everybody, and let's on to the experts.
Good afternoon, and I want to thank Senator Boyle for sponsoring this debate today. And thank you, Mr. Mcguire, for being here, and all of you for tuning in. For well over 2 decades, an ever-increasing number of terminally ill adults have gained access to the compassionate end-of-life care option of medical aid in dying in this country. 10 states and Washington, D.C. now authorize medical aid in dying, and it's evolved into an accepted end-of-life palliative care practice with well-established protocols and published clinical criteria for physicians to ensure that the highest standards of medical care are met. Study after study has shown that laws authorizing medical aid in dying have worked to enable terminally ill adults to avoid intolerably suffering at the end of life and to die peacefully in their sleep, at home, and surrounded by those they love. A relatively small number of people avail themselves of medical aid in dying in the end. Less than 1% of all deaths in the jurisdictions that authorize the practice involve medical aid in dying. But countless terminally ill people and their families gain the benefits of improved conversations about what they fear most about life's end and the peace of mind of knowing that there's an option that will allow them to avoid needless suffering. There has not been a single substantiated instance of misuse, coercion, or abuse, nor has there ever been a single incident of disciplinary action against a physician relating to participation in the practice. There's no evidence of heightened risk for patients in vulnerable groups, and studies have shown that insurers have no financial incentive to pressure terminally ill patients to accelerate their deaths. In short, we know an awful lot about how medical aid in dying laws are being used across the country and the positive effect they're having on end-of-life care for everyone, even those who never ask for it. These laws have created a new and improved standard for how we ought to be helping people. I could spend the balance of my time citing facts and figures, but instead I want to honor mothers as we're on the eve of Mother's Day weekend by addressing some of the most common misunderstandings about medical aid in dying through the lens of some of the mothers and their adult children who are involved in our campaign. Let's start with the misconception that we don't need medical aid in dying because people have access to excellent hospice and palliative care options. Or alternatively, that New York needs to invest more in hospice and palliative care. Let me tell you about Camille Parker, who died of bone cancer. She lived in the Hudson Valley and was cared for by her daughter, Shannon. Here's what Shannon says. My mom had only a couple of wishes. One of them was that she didn't want to be in pain. Shannon said nothing was working. None of the medications hospice had given us were working. She would wake up screaming, literally screaming, I can't breathe. Her lungs filled up with fluid and she felt like she was drowning. Shannon couldn't keep her promise to her mother, despite the fact that she was receiving what the family considered excellent palliative care and excellent hospice care. Shannon lives with the feeling of guilt every single day, and her experience is not uncommon. Here's the thing, we need to get better at hospice and palliative care. New York ranks 50th among all states in terms of appropriate use of hospice care among those who are eligible. That is unacceptable. We need to make sure that everyone eligible for hospice who wants it can get it. But we also have to improve the care that hospice delivers. While hospice services have provided relief to countless New Yorkers, my family included, even the best hospice and palliative care can't relieve all suffering. They can't alleviate all pain. But we can do 2 things at the same time in New York. We can expand palliative care options to include medical aid in dying, and we can improve the quality of and access to hospice and palliative care. This is not an either-or proposition. You may hear that pain isn't actually the reason that most people want medical aid in dying, and with good care, no one has to die in pain. And I'll make 2 points here. Denying that those who are dying don't experience pain simply belies the lived experience of so many of us who have watched loved ones die in pain despite good care. But not all suffering involves pain. Sometimes the suffering is deeper and more complex than that. So let me tell you about Fei Ho Yin, who died of incurable T-cell lymphoma just this past July. She was cared for in Brooklyn by her daughter, Monona. Monona said, "Mom asked me if we could move to New Jersey because medical aid in dying is legal there, but the logistics were insurmountable. It seemed like a cruel joke that salvation lay just a few miles across the river." By the end, Mom was just skin and bones. She struggled to breathe. She had lived a good life and discharged all of her duties faithfully. She couldn't understand why she should be made to suffer to the bitter end. My mom did not find suffering to be ennobling nor honorable. She regarded it as pure misery. For my mom, she experienced psychic suffering that built to a crescendo in the last year of her life. Her increasingly desperate search for some measure of agency robbed us of precious time that my family would otherwise have enjoyed. Let's talk about suicide for a moment. You may question my insistence that medical aid in dying is not suicide, but I ask you to consider these two facts. Those who commit suicide have chosen to die rather than to continue to live. In contrast, those who are terminally ill would like nothing more than to continue to live, but their illness is causing them to die. All they want is to avoid needless suffering. In fact, one way to prevent suicide is to actually give terminally ill adults the end of life option of medical aid in dying. This might sound counterintuitive, but I have seen far too many cases of people who take their own lives by violent means, in isolation, traumatizing their families and communities because they feel like there's no other way to stop the suffering and they can't bear it any longer. But there's something more nuanced here. The people who are asking for this end of life option are some of the most full of life people I have ever met. They love life. That's why I wish you could meet Jennifer Milich from Buffalo. Jennifer is dying of renal cell carcinoma right now. That's a rare and aggressive form of kidney cancer. Jennifer is not suicidal. Here's what she says. She says, "I desperately want to live, to be here for my son, daughter, and granddaughter. My death is imminent, and I want to ensure that it's as peaceful as possible." She says, "I don't have time for politics. My concern isn't politics, it's about peace at the end of life." Jennifer, by the way, is a strong disability rights advocate, fighting for the rights of her son, Ethan, a young man living with profound disabilities. I got a call from Ethan last week around 10 p.m. He just wanted to talk because his mom kept asking him why. Why can't I get help to die? He knew there wasn't anything I could do to help. He just wanted to talk to someone who understood. He told me that she kept saying, "This is no way to live." Our failure to act this year will mean that Jennifer will continue to suffer until she dies. I have traveled all over this state, from Buffalo to Brooklyn, from Montauk on Long Island to Malone in the North Country, and I've listened to thousands of New Yorkers. What I know is that their desire to prevent our loved ones from suffering unnecessarily is universal. It spans all demographics, including party lines and religion. We know that there's another way. With more than 1 in 5 people in the US now living in a jurisdiction where they have access to medical aid in dying, more and more New Yorkers are sharing their stories with us about the peaceful deaths their loved ones who live in other states like New Jersey, Maine, and Vermont have had. So let me end by introducing you to Myra Shulman and her mom, Beverly. Myra lives in Ithaca, and her mom, Beverly, died in 2017 from incurable metastatic colon cancer. Beverly had access to medical aid in dying because she lived in California, a state that had just passed the legislation. Myra says, "When the time came, mom lay on her own bed in her own home with her daughters at her side, holding her, and swallowed her prescription. Within a few minutes, she slipped gently into unconsciousness. For the following 5 hours, my sister and I and our husbands were at her side, cuddling, talking, and singing to her as her breathing changed, slowed, and eventually stopped. It was such a peaceful, gentle, truly beautiful way to end a life." Look, the most important thing that I can leave you with is that when this law passes, and it eventually will, I have no doubt, nothing will change for those who don't believe in medical aid in dying. But everything will change for those who need it. The question is, how long will lawmakers wait? How many more people have to die suffering? New Yorkers deserve better. The power to do better is within our reach. Thank you.
Thank you so much, Corinne. Truly appreciate it. And now we'll have us hear from Jason Mcguire. Mr. Mcguire.
Senator Boyle, first I want to thank you and your staff for this opportunity. I welcome the platform that you've provided for both Corinne and I to talk about an issue of such importance as that of assisted suicide. It's an unfiltered discussion, and it's good to have those. It's something we don't often see among elected officials or in legislative bodies. And Corinne, I want to thank you as well for opting to represent your side of the argument in today's debate. To those viewing, thank you for taking the time to carefully weigh the arguments both for and against assisted suicide. You know, advocates of assisted suicide frequently present their legislative agenda as a matter of compassion for persons suffering with terminal illnesses. But this rhetoric is deeply misleading. The proposed bill could encourage patients to choose physician-assisted suicide based on faulty diagnoses. The proposed legislation would allow an attending physician to prescribe lethal drugs to a patient if the patient's illness and that physician's medical judgment and in the medical judgment of a consulting physician will result in death within 6 months. These provisions base a life or death decision, whether or not to prescribe lethal drugs in a patient, upon a medical prognosis. And in so doing, the bill's sponsors presume a nearly omniscient level of predictive capability on the part of the medical community. When in fact, a major study of physician prognoses in Chicago revealed that of 468 predictions, only 20% were accurate in predicting when death would occur. In another study published in the Journal of the American Medical Association, no group accurately predicted the length of patient survival more than 50% of the time. When J.J. Hansen, a young husband and father, a New Yorker, was diagnosed with an aggressive form of brain cancer, physicians told him that he had 4 months to live. After undergoing a difficult course of treatment that included surgery, radiation, chemotherapy, and a clinical trial for an experimental drug, Hansen outlived his prognosis by more than 3 years and became a nationwide voice of opposition to assisted suicide prior to his death in 2017. Under an assisted suicide law, a patient in Hansen's situation might choose to take his own life based upon an incorrect prognosis. And in so doing, that patient would miss the opportunity to extend his life or even recover altogether by continuing to fight his illness. The possibility is deeply troubling. The bill presupposes that there's no way to relieve the pain suffered by some terminally ill persons, and that such persons must choose between dying in agony and taking their own lives. The problem, as Corinne brought out, is it's not just physiological. It's also mental, emotional, relational, and spiritual. And that we can agree. It's unique to every person, varying from person to person. However, advocates of assisted suicide do seem fixated on the physical pain. In assisted suicide, one is not alleviating the suffering, they are eliminating the patient. Palliative care provides compassionate, effective, and ethical methods for easing the suffering of terminally ill patients. The whole person component of most hospice and palliative care programs is designed to help patients and their families cope with their physical, mental, emotional, and relational burdens. And yes, with so little hospice utilization in our state and palliative care with so far to go, I have to ask why we're heading down the path for assisted suicide now. Actually, I think we should be pursuing greater forms of palliative care and hospice care. When we're last in the nation, why not improve that? Why not work on that area and see if that doesn't rectify many of the problems that are being described in these areas? New York's laws against assisted suicide have been upheld by multiple courts. Both the New York Court of Appeals and the Supreme Court of the United States have ruled that New York's existing laws against assisted suicide are constitutional. On September 7th, 2017, the New York Court of Appeals released its decision in Myers versus Schneiderman. In Myers, the plaintiff sought to establish a right to physician-assisted suicide under the Constitution of the state of New York. In a 5-0 decision, the Court of Appeals ruled that the Constitution of the state of New York does not guarantee a fundamental right to assisted suicide. The Court of Appeals reasoned as follows, and this part I want to read. The state may rationally seek to prevent the distribution of prescriptions for lethal dosages of drugs that could, upon fulfillment, be deliberately or accidentally misused. The state has a significant interest in preserving life and preventing suicide, a serious public health problem. The state's interests in prohibiting assisted suicide include prohibiting intentional killing and preserving life, preventing suicide, maintaining physicians' roles as their patients' healers, protecting vulnerable people from indifference, prejudice, and physiological and financial pressure to end their lives, and avoiding a possible slide toward euthanasia. The legislature of this state has permissibly concluded that an absolute ban on assisted suicide is the most reliable, effective, and administratable means of protecting against its dangers. The proposed bill would place unreasonable burdens on physicians and would irreparably damage the physician-patient relationship. If physician-assisted suicide were legalized in New York, physician-patient relationships would never be the same. I want you to think about the fact that when young medical college students go off, they're inspired by the stories of Patch Adams, not Jack Kevorkian. They go to be healers and not killers. Under the proposed bill, neither an attending physician nor a consulting physician is required to refer a patient that requests assisted suicide for mental health evaluation unless that physician believes that the patient may lack capacity to make an informed decision. Patients treating terminal illnesses are not likely to be specialists in mental health matters, and decisions about mental health evaluations for patients seeking assisted suicide should not hinge upon those physicians' perspectives on their physicians or on their patients' mental health. In fact, New York's law already strikes the right balance between patient autonomy and states' interest in protecting human life. Under penal law, intentionally assisting someone in committing suicide constitutes second-degree manslaughter. Intentionally assisting someone in attempting suicide is a Class E felony. But on the other hand, New York law does allow consenting adults to request DNR orders or do not resuscitate orders. New York law recognizes a bright line between allowing an individual to refuse medical treatment and not allowing an individual to act in a manner that affirmatively causes the death of another. That line should not be crossed. Assisted suicide legislation would cross or even erase the line by empowering physicians to prescribe lethal drugs. But the proposed bill would motivate both insurers and patients to choose physician-assisted suicide as a cost-saving measure and could influence patients to choose death over life. From a social justice perspective, physician-assisted suicide is deeply problematic. In August 2008, ABCnews.com reported the story of Barbara Wagner, a one-time cancer survivor in Oregon. Ms. Wagner, a 64-year-old great-grandmother who resided in low-income housing, learned that her lung cancer had recurred. Her physician prescribed an expensive medication. However, the Oregon Health Plan, Ms. Wagner's state-sponsored insurance, they sent an incredibly callous letter. And the insurer notified Ms. Wagner that assisted suicide, which is legal in Oregon, would be covered. While the proposed legislation in New York would prohibit insurers from presenting information about assisted suicide to patients who have not requested it, it would not prevent insurers from declining to cover life-saving or life-extending treatments. Such an action by an insurer could leave terminally ill patients with limited options other than physician-assisted suicide. And yes, consider the implications of right-to-die legislation for people with disabilities. Physician-assisted suicide laws normalize assisted suicide as an acceptable response to being disabled. Assisted suicide advocates often indicate that if they lost their independence or lost control of their bodily functions, that they would prefer an early exit. These kinds of statements are damaging to those in the disability rights community. These individuals are often dependent on those around them for things like basic care, transportation, even eating and drinking. Disabled, and many elderly people are already treated as having a lesser quality of life than those who don't have those disabilities. However, they are just as deserving of suicide prevention and better long-term care than anyone else. Yet these people often are already facing various forms of medical discrimination, and right to die legislation creates a coercive duty to die for people who might require assistance with daily living and who often cost more to care for. And finally, the proposed bill would create an incoherent public policy in which the state of New York would discourage suicide in most circumstances, but facilitate it in others. Suicide contagion is real. A CDC report revealed that during the 20-year period that followed the 1997 implementation of Oregon's assisted suicide law, suicide rates in that state were higher than elsewhere in the nation, 40% higher. Suicide among those aged 35 to 64 increased 49% in Oregon, opposed to 28% nationally. Assisted suicide does not occur in a vacuum. When a society endorses suicide for some, it naturally causes others experiencing pain in their lives to consider suicide as a means of escaping pain or suffering in their situations. My words are not ignorant of the very real suffering that some facing terminal illnesses are experiencing, but there is a larger picture that our culture must confront. How many suicides are we willing to accept in exchange for the normalization of assisted suicide and the legalization of medical aid in dying? The legislature seems to understand that suicide is a problem. There are no less than 16 bills that have been introduced that seek to address the issue of suicide, from establishing suicide prevention and mental health crisis hotline systems, to establishing an LGBT youth and young adult suicide prevention task force, to a Black youth suicide prevention task force, the inclusion of suicide prevention resources when you issue a warrant of eviction, to relating and reporting of a veteran suicide, to creating a Veterans Mental Health and Suicide Prevention Task Force, to establishing a Latina Suicide Prevention Task Force, and even creating the Rural Suicide Prevention Council. So I ask again, how many suicides are we willing to accept in exchange for the normalization of assisted suicide and the legalization of medical aid in dying? How many veterans a year? How many of a lower socioeconomic background or facing expulsion from their homes? How many Latinas? How many LGBT or Black youth? How many? Well, if it's even one, what if it's a son or a daughter or a grandchild of someone viewing this video feed? I don't want it to be mine. And I don't want to live in a culture that encourages suicide for some and tacitly endorses it for others as well. For these reasons, members of the New York State Legislature and the public should reject this bill and all other efforts to legalize physician-assisted suicide.
Thank you very much, Jason. And thank you again, Corinne, for your incredibly insightful comments and passionate advocacy for your positions. I'm going to open it up now to questions. We do have some in the chat. I'd first like to acknowledge my colleague, State Senator George Borrello from Western New York has joined us. Thank you, George. And the first, several of the questions are in the chat, so I will go to them first. One actually was directed towards me from Annette Hansen. Annette asks, if New York adopts this law, will the state require this to be offered in state psychiatric facilities as California has done through their code? I think that the answer to that is we don't know. Obviously, the bill could be amended quite a bit, or as this discussion, not to say that this legislation would go through as is, but whether that would be the case in doing it in New York State psychiatric facilities is an open-ended question. I think that both experts would agree with that. One question we have from Amanda Kavanaugh is for Jason. When you say the Chicago study shows that 20% of the prognoses were accurate, do we know if the patients lived shorter or longer, or can you give a link to that study? You could perhaps have someone put it in the chat if you don't know it offhand.
Yeah, we can find something and get you that in the chat or provide it afterwards as well. And regarding the question, can you just read the 20% part again, what you were looking for, longer or shorter?
When you referenced the study, you said that 20% of the prognoses were accurate, showing most were not. Do we know if the patients lived longer or shorter than the prognosis that was given?
I don't have it in front of me. I don't know if it is longer or shorter. I assume it's probably a gathering of both.
Right, okay.
Senator Boyle, I can answer that question.
Oh, please, great. Thank you.
Studies have shown that when physicians issue these prognostications, they vastly overestimate how long someone is going to live by 5 times. So Jason's right. 20% of the time they're right, 80% of the time they're wrong, or they're estimating a longer period of time. So basically, doctors are telling patients that they're going to live a much longer amount of time, which is why they're classified as having a wrong prognosis. So I think it's really important to put that statistic into perspective.
Okay. But I don't think that was true of the journal for the JAMA study that was cited. So, we should go ahead and take a look at that again. Let's be careful with that.
Okay. The next question is from Yale Rosen for Jason. When palliative care fails and the patient has unbearable suffering and wishes to die, why would you wish to prevent medical aid in dying, which is not assisted suicide? If basically, obviously, if they're in tremendous pain is the question.
Well, I think the courts actually have already ruled regarding this being suicide. And I know that euphemistically, the language is sought to be changed to something different, but even the courts that I read from indicated that there was a parallel here to suicide. That was the language that was used. So I don't see a difference. I know there are some that try to make a distinction saying that people that commit suicide don't want to live any longer. That's not entirely true. It's a cry for help. And I think that there are people that are crying for help that, yes, some commit suicide, there are attempted suicides. And I don't see a great deal of difference between people that are depressed or are in despair because of a physical pain or debilitating disease and then touches other areas of their lives than someone who is also suffering from more general suicide.
Senator Boyle, can I respond?
Of course.
So, the American Psychological Association, the American Association of Suicidology, a group dedicated to preventing suicide, the American College of Legal Medicine, all of them have rejected the use of suicide when you're talking about medical aid in dying. And I think it's important that we're hearing that word over and over again. It inflames the debate. Suicide rates have risen across the country, and Western states struggle with suicide rates higher than the national average. Access to guns is a major reason. Guns are used to commit more than half of all suicides, but there are other reasons. An increase in mental health conditions, economic despair, general despair, easy availability of lethal street drugs. And when my opponent talks about preventing suicides, and he uses veterans and suicides over and over again, what I would say is Captain Doug Greenwood, who worked at the pit after 9/11. He was an NYPD officer and he contracted cancer. And for 10 years, he was receiving treatment for cancer. He was on an oxygen tank. He took his own life with a gun at the entrance to a public park in Long Island. He was suffering and he could see no end to that suffering until his terminal illness took its course. So when we're talking about preventing suicides and preventing suicides from those people who are our heroes, I would posit that we need another way.
Okay. Thank you. The next question is from Heather Pope, and it is for Corinne. Heather asks, what is the difference between terminal illness and a disability? Do you have a response to claims of ableism?
Oh, absolutely. We share values with the disability rights community, the values of self-determination and autonomy. A terminal illness is an illness, and this is defined in the bill as being one that is incurable and irreversible. One can only qualify for medical aid in dying if they have a prognosis of 6 months or less, which is exactly the standard for when you can get into hospice in most states across the country. New York, we've done better. We allow people to access hospice services at 1 year. But the bill allows people who are terminally ill defined as incurable and irreversible with no more than 6 months to live. That is substantively and absolutely different from someone who is living with a disability. They're living the rest of their lives differently abled, totally different from someone who's dying.
Okay.
So
Jason,
under the definition, so under the definition of the legislation that was cited there, if a person who is a diabetic stops taking their insulin, they would now classify under this bill as eligible for assisted suicide.
Absolutely not true. That is
It's
not true.
based on the
Incurable
definition and based on the
irreversible.
Oregon, exactly, diabetes is incurable. And if they stop seeking treatment for it, they are. The Oregon reports even indicate that people with diabetes have accessed assisted suicide. So it does happen.
I'd like to respond to that.
Of course.
Medical aid in dying is about an illness that can't be cured. Mr. Mcguire is citing statistics from Oregon. In total, since the Oregon law went into effect, there have only been 1,600 deaths. Diabetes is not in and of itself a terminal illness. Even with the appropriate medical treatment, over time, it can develop into complications such as chronic kidney disease and end-stage renal disease, a process which takes years. So when you see that listed in Oregon and only in Oregon, these are people who have had diseases that have progressed from diabetes to other diseases. So I just want, you're asking people to be careful with the statistics. I would refer people to the Oregon reports and to studies that show that diabetes in and of itself does not qualify you. In no way does it qualify you for medical aid in dying.
Okay, thank you. And we'll go on to the next question. It's from Lisa Hunkinen. It's for Corinne. Corinne, you referenced a peer-reviewed medical journal that from a statistic that said it's 5 times overestimating on prognosis. If you could, the facts and figures are important, so we need a credible source. If you could share, perhaps in the reference to that study.
Absolutely. It's from a 2000 British Medical Journal study. And we also have a study from, well, we've got some other studies we'll put in the chat as well.
Okay. The next question is by Dawn Eskew. It's for Corinne. We are told that there are safeguards in New York State Bill A4321, the same as Bill S6471. The question is, how is a patient protected when there is no oversight for the patient when he or she obtains the lethal drug, and there exists an inpatient heir who can't wait and kills for the estate money behind closed doors? She also asks, how is the patient protected from murder when the death certificate is required to list the cause of death due to natural causes or death due to illness? Just if Corinne, if I could interject, this is actually one of the issues that I've struggled on, and I can, this is a very tough issue for me. About the concern of heirs. I know, like, for example, my parents, they passed quickly, thank God. But if they had lingered, I know they were the type, oh, we saved this money for our kids and we wanted to give it to them. And not that my siblings and I were the type to put pressure on them, but there are others that perhaps would, to say, okay, we maybe hasten this, even though I don't want to do it, to see what I can leave for my children.
Senator Boyle, I so appreciate your concern about this. I think we need to remember that we're talking about people who are dying. We're not talking about people who are not dying, whose heirs want to see them inherit their money quicker. It's not about that. These people are within 6 months of death, many of them much closer to death. Look, when my dad was dying, we went home with home hospice care. The medications that we had at the bedside were far more lethal. And I know that that sounds really strange to people than medical aid in dying medication. Let me just describe, this is not a death pill. This is not something that can be administered to someone easily. This is a compound medication that has to be self-ingested by someone. It's not an injection. It's not something that you can slip into someone's drink or applesauce. This is a very bitter mixture that has to be self-ingested by someone. And the penalties for forcing someone or, otherwise administering that medication to them it's a felony. It's a felony as per the Medical Aid in Dying Act. What I would say is, if you have a nefarious relative, that is happening now. That's happening now without a medical aid in dying law in place. You've got relatives who, in your scenario, they could over-medicate someone with the medication readily available that we're sending home to people without oversight. You know this. They could under-medicate the person. They could fail to bring them to the doctor. They could fail to care for them. Those things are happening now. What medical aid in dying does is it puts the power of what the end of life looks like in the patient's hands and the patient's hands alone. That's very different from the abuse that people are vulnerable to right now.
Okay, thank you. Jason, would you like to weigh in on this?
Well, that's a very rosy way of portraying the picture, but if we're to believe that people at this stage are so weakened that they can resist someone who is giving them a bitter pill or a bitter taste, there's so many opportunities for this to be rife with abuse. It is a concern. Just before I came over here today, I was hastened over to a neighbor who had fallen victim to some scammers. I mean, there are just always people who are looking for an angle. And when it comes to assisted suicide, when death certificates are filled out, the cause of death is it's listed as the underlying condition. And so you don't even have an effective means to go back and to figure out exactly what has happened in so many of these situations. It's no wonder that we're pointing to euphemistic language when we're forced to literally lie on the death certificates concerning the cause of death.
I'd like to address the death certificate issue.
Sure.
There are two reasons for a death certificate. The first is to settle the estate. The second is for public health purposes. Why shouldn't the underlying illness be listed on the death certificate? There is a report required to go to the legislature, to go to the Department of Health about the use of medical aid in dying. So no one's deceiving anyone by putting the underlying cause of death. If someone dies because too much morphine was administered, or if someone dies because they stopped breathing because the DNR meant that, the breathing tube was disconnected, the death certificate doesn't say that they suffocated or they had an overdose. The death certificate says the underlying cause of death. And that's because as a public health matter, we want to know how many people die of cancer. We want to know how many people die of COPD and neurological disorders. The statistics about who is using medical aid in dying is very clearly kept by the Department of Health. So there is no sort of hiding the fact that people use medical aid in dying. The report is required.
But again, they're not dying because of the underlying condition. They're dying because of the poison that they have taken into their bodies. That is the cause of death.
So if I could interject, it actually gets to one of the questions that were asked, and it could go to either one, I guess. As either you may know what goes on in other states and what potentially would go on if this legislation was passed. It asks, Linda Holler asks, I understand the lethal drugs are issued to the patient and they take them home and put them in a cabinet to take them whenever they are ready. What happens if they decide not to take them? What happens to the drugs if the person dies before taking them? And what safeguards are in place to make sure that lethal drugs do not get into the wrong hands? My question is that true that when this happens, they are basically sent home with the drugs, or somebody, a third party's given it to them to bring them to their house?
So a few things. I'll back up and say that there has never been a single substantiated instance of misuse, coercion, abuse, or diversion or accidental ingestion of these drugs. Never. These laws have been in effect since 1997, and we don't have a single cited case of this happening. What happens, Senator Boyle, is that people get the prescription for medical aid in dying, and they may not fill it until they're ready. And in fact, between a quarter and a third of all people who receive a prescription never use it. Many of them don't even pick it up. For them, it could be the expense. It could be that they're not ready to pick it up. For those who get the medication and put it in the cabinet, New York's Medical Aid in Dying Act actually has a provision that requires that those drugs be handed over. Do you know what I was told when my dad died, what we should do with the morphine? I was told that we should put it in cat litter and put it in the trash. That's horrible. Those drugs are subject to diversion and misuse by relatives. The medical aid in dying drugs are not. So for that small percentage of people who actually do pick up the medication, put it in the cabinet and never use it, there are provisions that require them to turn those drugs back over.
Jason?
No, I mean, nothing more to add to that.
Yeah.
But we are concerned about what happens with those death certificates, and we can avoid that all we want. It is difficult to track what is happening with these people when the cause of death is not listed on the death certificate, merely the underlying condition.
How is it
Okay.
difficult to track when the reports are required to go from the treating doctor to the health department? How is that difficult to track?
The death certificate that would be publicly viewable, that's available, people can, track that, does not have the accurate cause of death, period. That's a problem.
Okay, so if I could, the next question is from Sam DeWitt. It's for Jason. Should a religious institution be able to block my access to care at the end of my life? He says, I'm not a Catholic, so why should my decision-making be impacted by the Catholic Church or any religious institution?
Well, I mean, that's a separate issue regarding religious liberty concerns. I mean, that would be something that would have to be looked at as to, how that would be handled in separate legislation. It really wouldn't be dealt with under the current bill. But you don't have to be a religious person or a person of faith to believe that it's wrong to encourage suicide or to prematurely encourage someone to take their death.
Okay. Corinne, would you like to comment on that?
No, I mean, look, I think that my family's Catholic. I'm Catholic. I just believe that everyone should be able to die in a way that's consistent with their faith and their values and their beliefs. And I do think that, I do think that religion is getting in the way here. So, I mean, I'll stop there. I think that everyone should be able to die in a way that's consistent with their faith.
Thank you. Thank you. Well, I can say we could go on with this debate for days, no question about it. And it's been incredibly insightful. I would like to leave, 4 or 5 minutes for each of the participants to give closing arguments if you'd like to. Corinne, you went first time. So Jason, would you like to go first now?
All right. Well, again, thank you for the opportunity to share these thoughts today and these concerns with assisted suicide. This was an issue that really was about a decision that an individual makes in a vacuum. We probably wouldn't be having this discussion. I disagree with it. You might disagree with it. You might agree with it. We wouldn't be having this conversation. But we don't live in a vacuum, and we live in a community. And certainly the events of the last year through the pandemic have demonstrated the importance of community and that we really aren't living alone. And it's important that we understand the decisions that we make impacts one another. We're understanding that through the days we've gone through and what we're coming out of. And I would argue that what is happening in this situation matters as well. That's why I do keep coming back to the word suicide, because assisted suicide is still suicide. And when we're fighting suicide contagion among our teenagers, and we're fighting suicide in so many fronts today, and we do see it on the rise, why would we want to go further down that road and encourage assisted suicide? So as much as some may want to think this is a decision that's about just as an individual, it's not. We're a part of community, and the decision that is made in public policy affects other areas as well. And so I hope that the legislature and the public at large will recognize that assisted suicide is still suicide and reject physician-assisted suicide legislation.
Thank you, Jason. Corinne?
When I first thought about taking this job to lead the campaign to pass a medical aid in dying law here in New York, I did my research and I found the New York Task Force on Life in the Law report in 1994. That report was issued before any state in this country had ever approved a medical aid in dying law. And in that report, they warned of all of the things that Mr. Mcguire mentioned in his opening statement. Every single one. You could read that report and not be able to distinguish it from what Mr. Mcguire said here today. The reason I say this is that our opponents' arguments have never changed. We are a quarter of a century since then, since 1994, and these fears that Mr. Mcguire is bringing up, the use of the word suicide over and over again, talking about veterans, talking about vulnerable communities. These are all things that the task force said before we ever had experience with medical aid in dying in this country. When Oregon passed the law in 1994, it went through the courts, and the court said, this is a decision for legislatures. And so that's what's happened. Year after year, we've seen more states authorize medical aid in dying. They've considered the facts. I led the campaign in New Jersey to pass a medical aid in dying law. We encountered the same exact arguments. You know what? We passed that law and it went into effect in August of 2019. And what have we heard from that state? Nothing bad has happened. Nothing bad has happened. But what I hear from family members, from doctors, from the Department of Health, from professional medical associations, is that this option is improving end-of-life care for everyone because it's improving the conversations that people can have with their healthcare providers about what they fear most at the end of life. And whether they're then going and receiving hospice and palliative care, or whether a small number of them are asking for the relief that medical aid in dying provides, that's what's happening in New Jersey. And so we don't have to theorize about these fears about what could happen, about, the harm to vulnerable populations. We've seen it in action, and nothing bad has happened in the 2 decades since Oregon's law went into effect in 1997. Since COVID-19 has devastated so many of our communities, New Yorkers can't avoid talking about death and dying any longer. And what COVID-19 taught us more than anything else, among so many other things, is what a bad death looks like. Dying alone in a hospital, connected to machines without the presence or touch of loved ones. I think we can all agree this is not the kind of death that any of us wants. We should pass a medical aid in dying law. We should give this compassionate option to New Yorkers that our neighbors in New Jersey, Vermont, Maine, and all of these other states now offer. There's no reason why a zip code, a mountain, a river should separate us from this proven practice that allows people so much comfort at the end.
Thank you, Corinne, and thank you again, Jason. Really tremendous presentations, and you've given us a lot to think about in the coming weeks. And thank everyone for participating and signing on. This is tremendous. This is just what we wanted to get learn from this and get out of this. We are hoping to have more of these debates in the coming weeks and months. And for those of you, whatever side you're on, or if you decided today you're still thinking about this important issue of aid in dying or assisted suicide, however we want to say it, please contact your legislator and let them know how you feel. It's an important process. So I think there may be some movement on this bill one way or the other. So it's going to be a upcoming debate in the coming weeks. There's 1 month left of our session this year, and a lot of things that will be going on, but this may well be one of the most important issues discussed. Again, thank you to our experts. Thank you for everyone for participating. Thank you to my staff, and have a great weekend, everyone. Thank you so much.
Thank you.